Welcome to this Step 2 clinical knowledge review on common fractures test-taking strategies. This video is brought to you by Roadmap to Residency. Today we are going to break down the most common question patterns you will see on your board exam for orthopedic fractures and teach you strategies to pick the right answer quickly and confidently. We will cover hip fractures in elderly patients, wrist and ankle fractures, compartment syndrome, and fat embolism syndrome. Remember, the goal here is not to re-teach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the musculoskeletal and emergency medicine sections of your review resources and question bank before or alongside this video. Here is what we are going to cover today. First, we will learn how to recognize high-yield question stems for common fractures, compartment syndrome, and fat embolism. Second, we will apply specific test-taking strategies for questions about hip fractures in elderly patients, wrist and ankle fracture patterns, and orthopedic emergencies. Third, we will master the next best step question format that the boards love to use for fracture management decisions. This video assumes you have some baseline knowledge from your review resources. We are here to sharpen your test-taking approach so you can pick the right answer faster on exam day. Our first strategy is the elderly hip fracture framework. When you see a question about an elderly patient who fell, immediately classify the fracture as intracapsular or extracapsular because the management is completely different. For intracapsular fractures, meaning femoral neck fractures, the big worry is disruption of the blood supply to the femoral head, leading to avascular necrosis. A displaced femoral neck fracture in an elderly patient is treated with hip arthroplasty, either hemiarthroplasty or total hip arthroplasty. For extracapsular fractures, meaning intertrochanteric or subtrochanteric fractures, the blood supply is preserved, so avascular necrosis is not a major concern. These are fixed with a sliding hip screw or intramedullary nail. The boards absolutely love testing this intracapsular versus extracapsular distinction, so make it your first mental framework whenever you see an elderly hip fracture question. Strategy 2 is the orthopedic emergency checklist, covering compartment syndrome and fat embolism. These are the two emergencies the boards test most heavily alongside fractures. For compartment syndrome, the hallmark buzzword is pain out of proportion to the exam findings. The classic setup is a patient with a long bone fracture, usually the tibia, who has worsening pain despite adequate immobilization. Pain with passive stretch of the compartment muscles is the most sensitive early clinical finding. You may also see paresthesias and tense swelling of the compartment. Remember that loss of pulses is a very late finding, and waiting for that means you have already missed the diagnosis. For fat embolism, remember the classic triad: petechial rash, respiratory distress, and neurologic changes. This occurs 24 to 72 hours after a long bone fracture or orthopedic procedure. The petechial rash is typically on the chest, axillae, and conjunctivae. This is a clinical diagnosis, and the treatment is supportive. The boards want you to recognize the timing and the triad. Now let us go through high-yield stem recognition for fracture questions. For hip fractures, the classic stem is an elderly patient, usually a postmenopausal woman, who falls and now has hip pain with inability to bear weight. The physical exam finding of a shortened and externally rotated lower extremity is your buzzword. The imaging will show you where the fracture is, and that location is everything for determining the treatment plan. For compartment syndrome, the stem gives you a patient who had a fracture, usually of the tibia or forearm, and now has escalating pain that seems worse than it should be. Pain with passive stretch of the muscles in the affected compartment is the most sensitive clinical finding. When they give you compartment pressure measurements, remember that a pressure within 30 millimeters of mercury of the diastolic blood pressure is the threshold for surgical intervention. For fat embolism, the timing is the giveaway. It happens 24 to 72 hours after a long bone fracture. The patient develops sudden difficulty breathing, confusion, and a petechial rash on the upper body. This is a clinical diagnosis, and the treatment is supportive care. Let us work through our first practice question. A 78-year-old woman with osteoporosis presents after a ground-level fall. She has severe left hip pain and cannot bear weight. Her left lower extremity is shortened and externally rotated. Radiographs show a displaced femoral neck fracture. What is the most appropriate management? Take a moment to think about this before we walk through the answer on the next slide. Remember to focus on the fracture location and whether it is displaced. Let us break this down step by step. Step 1. Spot the pattern. Elderly woman, ground level fall, hip pain, shortened and externally rotated lower extremity. The imaging shows a displaced femoral neck fracture. This is an intracapsular fracture, which means the blood supply to the femoral head is at risk. Step 2. Apply the rule. The board rule you must know is that displaced femoral neck fractures in elderly patients are treated with arthroplasty, not internal fixation. The blood supply is already compromised, so trying to fix the fracture in place carries a very high risk of avascular necrosis. Step 3. Eliminate wrong answers. Open reduction and internal fixation is appropriate for younger patients who need to preserve their native hip or for non-displaced fractures. A hip spica cast is non-operative management and would be inappropriate for a displaced fracture. A sliding hip screw is used for extracapsular intertrochanteric fractures, not intracapsular femoral neck fractures. The correct answer is B, hemiarthroplasty. Here is our second practice question. A 25-year-old man arrives after a motor vehicle collision with a closed tibial shaft fracture. 6 hours later, he has severe worsening pain in his lower leg despite receiving intravenous pain medication. The leg is tense and swollen, and passively extending his toes causes extreme pain. What is the most appropriate next step in management? Think through this one carefully. The key phrase here is pain out of proportion, and the timing after a long bone fracture is critical. We will walk through the answer next. Let us work through this answer. First, recognize the emergency. This question is textbook compartment syndrome. You have a tibial shaft fracture, which is the most common fracture associated with compartment syndrome. The patient has worsening pain despite adequate pain control, a tense swollen leg, and pain with passive stretch of the compartment muscles, specifically pain when the toes are passively extended. These are the classic findings the boards want you to recognize. Now, why is emergent fasciotomy the answer? Because compartment syndrome is a surgical emergency. When the clinical presentation is this clear, you do not need to delay for compartment pressure measurements or other studies. Every minute of delay increases the risk of irreversible muscle necrosis, nerve damage, and potential limb loss. Increasing pain medication only masks the worsening compartment pressure. A computed tomography angiogram is for evaluating vascular injury, which is a different diagnosis. Applying a compression bandage would actually worsen compartment syndrome by increasing external pressure. The correct answer is C, emergent fasciotomy. Let us review fracture management pearls for the boards, because wrist and ankle fractures come up constantly. For wrist fractures, the most common pattern is a distal radius fracture from a fall on an outstretched hand. A Colles fracture has dorsal displacement, and a Smith fracture has volar displacement. The boards love testing scaphoid fractures because they are tricky. The classic presentation is anatomical snuffbox tenderness after a fall on an outstretched hand, but initial radiographs can be completely normal. The key teaching point is that if you have high clinical suspicion for a scaphoid fracture despite negative initial films, you should immobilize the wrist in a thumb spica splint and get advanced imaging such as a magnetic resonance imaging or a bone scan. Missing a scaphoid fracture can lead to a vascular necrosis because of the retrograde blood supply. For ankle fractures, know the Weber classification system. The key concept the boards test is stability. Stable fractures with an intact medial side can be managed without surgery. Unstable fractures involving the medial malleolus or the syndesmosis require surgical fixation. Also know the Ottawa Ankle Rules, which tell you when imaging is indicated after an ankle injury. Here is our third practice question. A 22-year-old man is 48 hours out from surgical fixation of a femoral shaft fracture. He suddenly develops shortness of breath, confusion, and tachycardia. On exam, you notice a petechial rash across his chest and axillae, and his oxygen saturation is dropping. What is the most likely diagnosis? This is a classic board question where the timing and the clinical triad are the keys to the answer. Think about what happens in the days after a long bone fracture. We will walk through it next. Let us break down this answer. The classic triad of fat embolism syndrome is respiratory distress, neurologic changes like confusion, and a petechial rash. What makes this question straightforward once you know the pattern is the timing? It occurs 24 to 72 hours after a long bone fracture, especially of the femur or pelvis. The petechial rash on the chest and axillae is the distinguishing feature. Now let us eliminate the distractors. Pulmonary embolism is a reasonable consideration in any postoperative patient with sudden dyspnea, but pulmonary embolism does not cause a petechial rash. Hospital-acquired pneumonia would present with fever, productive cough, and consolidation on imaging, not a petechial rash with confusion. Acute respiratory distress syndrome can be a downstream complication of fat embolism, but it does not explain the petechial rash or the specific timing pattern. The correct answer is B, fat embolism syndrome. Here is a critical test-taking pearl about fracture complication timelines. The boards love testing your ability to match a complication to the correct time frame after the initial injury. In the first few hours after a fracture, think about compartment syndrome, neurovascular injury, and hemorrhage. These are the acute emergencies. Within 24 to 72 hours, think fat embolism syndrome and deep vein thrombosis. In the first few weeks, watch for surgical site infection and hardware failure. For late complications developing over weeks to months, think avascular necrosis, especially after femoral neck and scaphoid fractures. Malunion and non-union present with persistent pain and deformity. Complex regional pain syndrome can develop after any fracture with burning pain, swelling, and vasomotor changes. When you see a board question about a fracture complication, the timing in the question stem is often the single biggest clue to the correct answer. Train yourself to look at the time frame first, then match it to the complication. That wraps up our review of common fractures test-taking strategies for Step 2 clinical knowledge. Remember to review the musculoskeletal and emergency medicine chapters in your board review resources and your question bank. Focus on fracture classification, the intracapsular versus extracapsular distinction for hip fractures, compartment syndrome recognition, and the fat embolism triad we covered today. Visit roadmap2residency.com for expert tutors and residency advisors who can help you build a personalized study plan and match into the residency of your dreams. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.